So we are going to start our next session. The next IC is on while chopping when the cataract doesn't crack, what to do. So we have varied speakers, experienced cataract surgeons pan India. We have Dr. Naren Shetty from Narayan Netralaya. Naren, please come on the stage. Then we have Dr. Meenu Mathan. He was the head of IOL clinic in Arvind, Madurai. Now he's practicing in Kerala itself, a high volume cataract surgeon. Then myself, Dr. Amit Porwal, I'm the chief instructor. We have Dr. Rajendra Prasad from Delhi. He is an innovator and he is the man behind the technique called as Terminator or the terminal chop. And we have Dr. Jeevan Tityal sir. He doesn't need any introduction, chief of RPC, a great surgeon. And we have, Dr. Meenu, please. So without wasting much time, basically, Dr. Krishna Prasad Kudlu is here. He needs no introduction. He is a member scientific committee, trainer in refractive surgery and cataract surgery at Udupi. So basically the concept of this IC is quite a few times we come across situation, we struggle while getting a crack, while chopping, while handling various types of cataract. So this course we have divided into different types of cataract and different techniques of chopping. When you are not able to get a good crack, how do we proceed ahead? So without wasting much time, I start with our first talk by Dr. Naren Shetty. He's going to talk on my way of dealing a soft cataract when it's not cracking. So this is a very, very important topic. A soft cataract, when it is not cracking, how are you going to deal with it? So the whole instruction course is video based. There will be multiple videos which our co-instructors are going to showcase. And what we'll do is, depending on the time, we'll decide whether to take the questions after each talk or we'll finish 2-3 talks first and then we'll take the questions pertaining to those topics so that we finish all our sessions on time. So Naren, are you ready?
Yeah. Is it playing? Okay, all right. Good morning, everyone. I would like to thank AIOS for giving me this opportunity. And okay, it's coming. Fine, fantastic. What if, I'm sure each one of us have had scenarios like this where we have a soft cataract and you're not able to chop it, right? So how do we do it? So one of the most important thing in chopping a soft cataract is your chopper or your dialer. It is very, very important because you need more surface area because you're trying to separate which is very soft. If you have something very thin, then you'll just go through and through. So this is one of the dialers which I've designed. So this is very useful to chop even soft, hard, black. Actually, this is just a dialer, not even a chopper. And this is more than enough. This is the only thing which I use. Now, the technique in chopping a soft cataract is, first thing is you have to do a little long chops. Take the chopper dialer into the periphery, move towards the tip, and you have to do a very deep chop. Once you come close to the tip, then move sideways. Now, this is very, very important. When you're moving towards the tip, should be a quick movement. When you're moving sideways, it should be a slow movement. Remember, quick movement towards the tip. Why? Because you are trying to cut it. When you're moving sideways, you're trying to separate it. You cannot go fast. If you go fast, you'll go through and through. Okay? So remember this small thing. Now I'll show you the same thing, scenario here. So it is a deep, long chop. When I'm moving sideways, I move it very, very slow. So this will ensure you have a direct chop even in these kind of very soft cataracts. Very similarly, I'll show you again. When I'm moving the chop towards the tip, the chopper moves. When I'm next to the tip, then I move sideways. I think the rest of the procedure is pretty simple. I think what I do is once I've separated it then I take one of the pieces, prolapse it. I usually remove my second instrument so that there's much better fluidics within the chamber, and then I remove the piece. And this is a technique which is very repeatable. Every time it's very, very consistent. Here you can see how friable all the pieces are. It's all, as you're chopping, it's all breaking apart. And even when I rotate, you can see it how it's falling apart. But the same thing, it's more of a mechanical. See, all my parameters is 0. I'm just under irrigation, and then I do the chopping. Now, let's have a look at a different technique. Let's say, okay, this is where, okay, the chopping didn't happen. So the first one is the regular deep chop, which I showed you earlier. So one more way to handle this kind of cataract is where you do a small trench. So you can see that a small trench, position your phaco tip in that trench, then you can chop it. Just like a modification of divide and conquer. Now, one more technique of handling these soft cataracts is where you create a well in the center first, okay? There you can see, right, where I create a well in the center. Do not remove the epinucleus or the cortex. create a saucer-like shape, like bowl like this, and then remove the epinucleus. So let's have a look how this looks like. So initially, even in this cataract, I just to show you how soft the cataract is. I'll just show you the primary chop, which I showed you earlier, where we create a very deep chop, deep long chop. So if you see closely, the separation is happening, but very, very slow. Okay. So what I do is, okay, let's try something else for this particular case. So I stop at this point, and what I do is I do the technique which I showed you here, where I create a saucer in the center. I remove the central part first. So you can see me removing the central part. So once the central part is removed, what I do is I redirect the phaco tip sideways, okay, and then hold the epinucleus, and the whole lens comes as a bolus. See, it's very simple. So coming to the next, I think here also, I think I'm showing the same, probably the same technique. Yeah, I think I'm showing the same technique. So again, here I just, showed you the way of doing that deep chops. Then, but if you remove the saucer, it is also a very easy, simple technique, and it's just a matter of seconds. You can remove the complete lens. Now, what if you want to do something else, okay, even more easier than what you're seeing here? It's a very simple technique where you, usually I operate with a 45-degree tip. It's very useful, 45-degree, because you can easily manipulate. With the 45-degree, what you do is you face the phaco tip downwards, okay? Once you face it downwards, so I'll just stop the video, I'll not, okay. I'll come back to that. So when you're facing the tip downwards, what you need to do is, if you can see my mouse, you have to move the phaco tip temporarily along the axis, right, left, right, left. You see how the pieces come out now? That's it. It's so simple. No chopping, no nothing. Again, just a matter of seconds. And this is very, very repeatable. Okay, so again, I go bevel down temporarily along the axis, right, left, and I'm done. It's very, very simple. Okay. Now let's play a different scenario. What if you have, let's say you have a plate like this. Okay, you don't know what to do. Okay, a simple thing is you take your dialer, go below the lens, lift it. While you're lifting it, press step 2 in your phaco tip. Okay, so that it holds it. Only 2, not 3. Then when you're in 2, you get a good hold, and then you can finish the rest of the piece. So the point is, when you have a scenario like a soft cataract, it can be pretty challenging, but always before you start the surgery, think of a particular technique which you're going to do, and have a plan so that handling becomes much more easier, because sometimes unconsciously we go into the surgery without thinking anything. We'll say, let's see, we'll try to do something, and in that attitude shouldn't be there. Always have a plan and then execute the same. Thank you for your time.
Thank you, Naren, for showcasing how you deal with your soft cataracts. We'll take a question after the 2 talks. Our speakers have to leave for another sessions also. So our next talk is by Dr. Minu Mathan. He's going to speak on, when I'm not able to crack the posterior plate of a hard cataract, what do I do? So this is a very, very important topic. Hard cataracts are very difficult to deal with, and especially the posterior plate. If that is not divided, your life becomes hell in that surgery. So Dr. Minu is going to showcase how is to deal with all these situations.
Thank you, Dr. Amit, for this opportunity. This is a very relevant topic regarding cataract, and now it has come down to focusing on to the okay. This is the way, but I can't see it now here. Anyway, so cataract sessions coming down to techniques of cataract surgery alone. Good, very focused course. Last time also we had a very good audience for this. So cracking posterior plate while chopping, no financial interest in this. So ideally, we should be cracking the posterior plate. So that is the basic idea, because we need to split it up into smaller pieces and finish off phacoemulsification. So ideally, let's see what happens here. So I would want to run it faster here. It is not possible.
Even the timer is 10 minutes. Yeah. All the talks are 10 minutes.
Okay. So showing 10 minutes anyway. This one. Okay, so adequate rhexis is one important thing. Staining it under air or viscoelastic like sodium hyaluronate is fine, but I would stain all these cases. Although they are brown, sometimes with the light, the eye tilted to an angle or something, you can see a reflex, but that I wouldn't take as a confirmation, because without a rhexis, we cannot do a perfect chopping in these kind of very hard nucleus. So here, I take out the cortex, which is minimal, and then do a deep trench in the center, which is more of a burrow than a full trench. Goes till the center. Then you know how deep the nucleus is, the depth of the thickness of the nucleus. And then I can go into the center, hold it with vacuum, and use an adequate chopper to chop this. I use a sharp tip chopper and do vertical chopping. There are different ways of doing it. There are different choppers which can be used, but this is the one which I am comfortable with. So this is a sharp tipped 1.75 millimeter long chopper, which goes through and through. And posterior plate, when you reach towards the posterior plate, see again, I'm continuing the split laterally, although it has split in the periphery. So chop again, hold it again, and keep going deeper into the plane which you have created, into the crack which you have created. Deeper and deeper, go closer to the area which is attached and split. And the hold is very important, should not go down into the foot pedal 3. So, because then you will eat off the nucleus which you're holding. So stay in foot pedal 2, have adequate vacuum, and let the nucleus be held very firmly. This is an unedited video. I'm just speeding it up and showing an unedited video. So holding it strong and then separating it from the posterior lamellae by in situ chopping further, going deeper into the crack is the way to finish off any nucleus ideally. So many cases it doesn't happen like that. For me, even yesterday also, many cases it won't happen like that. So if it doesn't happen, we should have a plan B. And for me, the plan B, which works for almost all the cases, is this. And I don't have a plan C. So this is the central trench which I do. So after that, the posterior plate, which is very leathery in some of the cases, will not split, even if you split very widely. So don't bother to split. So go to the area of within the rhexis when you're doing a vertical chopping. See the periphery which is chopping. It will happen very easily. Peripheral chops. And it will not extend towards the center or across the center. But don't insist. Don't chop the center. So chop only the periphery within the rhexis margin, because you are using a sharp chopper. And once we finish this, see the size of the tip which you are using. If you are using a smaller tip, divide it into further smaller pieces. This will be around 8 to 12 pieces. And then pull the peripheral chopped part towards the center. And then once it comes in, it will not come free. So you will not be able to emulsify it fully. But from the half part, upper part, it can be emulsified. See, again, I am sub-chopping it into smaller pieces and then pull it closer to you. And from there, it can be emulsified. Don't let it fall back. Don't emulsify it when it is inside the bag. It has to be held firmly. Hold has to be retained and bring it towards the center. And there, use the second instrument also to chop from the sides so that you can get further chops on the midway through the piece which you have cut. So then what will happen is you will get a disc in the center, and that disc can be lifted up. It can be held and lifted up. It can be held vertically. So this has become very small in size and it will never hit the endothelium. So once that is done, you can pick up the pieces and the posterior plate is still not cut. So that's not required. It becomes a thin plate which can be tilted and brought into the pupillary plane and just above the pupillary plane and finished off without chopping the center also. So if I am to do a case which does not split, I will do like this. I will not insist that it should split. Maybe ideally it should split. But if it doesn't split, this is the way I do all the cases. So many cases it doesn't split, and I keep doing this every day. So if you are very good at this, then in some situations where you need it, it may help. So this is one situation where there is a lot of fibrosis, the anterior capsule fibrosis, posterior capsule fibrosis, and inside the lens calcification. This is a very advanced kind of cataract, myope also. So once this kind of a rhexis is done, the phaco regularly normally happens. I'm going into the depth and I'm trying to chop. I see one white area there, a white area on the capsule. If you see such a white area on the capsule, it could be either a already open capsule, which is fibrosed, or an open capsule area which has been identified right now. So once that is there, a nucleus which is split up into smaller pieces can drop down one by one if it is an open posterior capsule. So this technique will retain the whole. Now I'm picking out the nucleus. It is now there is only nucleus in this case, but it can be just the nucleus. It can be brought out from the rhexis margin and phacoed in the iris plane, above the iris plane. Use lot of sodium, the viscoat, no financial interest in that. Even Orolab and other Indian companies also make the combination. Use that dispersive viscoelastic and finish off. Now I make sure that the central, once I finish this, see, I'm chopping the periphery. The center is not still split. So it's a whole single unit. It will not drop. So here you can see the, see, this is the problem with this. I can't, what I'll do is, I'll just play that video. That is a better idea. So that I can adjust the, can this come on? Okay, but still I can't use the, okay. So if you see the posterior plate and the fibrosis, and I confirm that it is not a posterior capsule rent, then it's all good. But till now, I was not sure whether I was doing phaco with an open capsule. So now see the white ring there. That ring could be an open capsule or just a fibrosis. But then I was not able to confirm because the nucleus was filling up the bag. So now I have confirmed it that the posterior capsule is still there. And now I place it back into the bag and then split further. So this can be split. See, once you cut from the periphery, you go catch it and keep splitting till the posterior plate, it splits. Only thing is, don't insist that you will split it with the whole nucleus, whole lens inside. These capsules are very fibrotic and thin. They don't stretch as much. So if you take out one small piece initially, then you will have enough space to split widely. So if you split widely, you can go further into the depth of the crack which you have already made and individually separate the connections which are there in the periphery. I think with this one pearl of cracking the posterior plate at the end with the peripheral chopping, if you can take it and practice it, you do it in every hard cataract. And to tell you, in ASCRS, this technique was long, many 10, 12 years, 15 years back, I think. It was presented by two people separately from two different countries and as a video, and both of those videos won prizes in the same category. And the technique was same, the peripheral flower petal, whatever name they give. This is the peripheral chopping for hard cataracts. Thank you.
Thank you, Dr. Meenu.
Yeah, now I invite our chief instructor, my friend, Dr. Amit Parwal, the member scientific All India Ophthalmological Society. He'll be talking about, in my stop and chop technique, I was not able to get a good crack. So how I do deal with it. Amit Parwal is a very good phaco glaucoma surgeon from Indore, been the part of scientific committee, and also part of ARC since last 6 years. Over to you, Dr. Amit.
Amit, you are not taking questions right now, no? No, I'll go and come back.
So any questions from the audience for Dr. Meenu's talk, because he's going to go to another session. So any questions, please come towards the mic and I can ask the question. This is a very important topic, very focused topic in the various chopping techniques or various types of cataract, how you're going to handle. Anybody, any question? So let's have a formal discussion. Actually, what Dr. Meenu had explained, the peripheral chop or the flower petal chop, this is a very, very important technique. The quick guide is you do the peripheral chop. If you tumble and get the posterior plate anteriorly, then you're chopping the cataract and emulsifying it becomes very, very easy. So without wasting much time now, we'll go to my talk. Let all the co-instructors come. We'll take the questions at the end again. So my topic, in my stop chop technique, I was not able to get a good crack. So how do I deal with it? So stop chop technique, we all know it has various names: trench, divide and conquer, stop chop, or a central trench and then divide into multiple chops. So what is the procedure described and what you have been taught? We have been taught that in this technique, you do a deep trench, which is sculpted slightly to the right side of the center of the lens, because most of us are right-handed and that's the way the trench happens. The nucleus is then fractured into two hemisections by using a bimanual technique, either with the phaco probe and Yasinski in one hand or a chopper in the other hand. or with two Sinski or two choppers, whatever instrument you're comfortable with. Now the phaco tip is buried deeply in the left section, and by moving the tip away from the larger mass, a second crack is made separating a pie-shaped cataract from the main nucleus. So the picture depicts all. Now the second instrument is held adjacent to the phaco probe, and a small down and away force related to the phaco tip will usually facilitate this cracking procedure. And after gentle rotation, additional fractures are created, and we can chop this each hemisphere into 3 or 4 pieces. So the standard picture which we have seen, which we have learned. But some days in my stop chop technique, a bad day in my OR, I am not able to get a good crack, whether it's a soft cataract, hard cataract. How do I deal with that? I usually practice only stop and chop technique. So we have our focus co-instructors who are focused in the various techniques. Like Dr. Kudlu is going to talk on direct chop. I'm going to talk only on stop chop because that is the technique which I usually follow. So now what happens is when I'm not able to crack and I land up, it's like a vicious cycle. We don't know how to deal with it. We lose our patience. So no, we should have plan B, plan C in the thing. So in the stop chop technique, the depth and the length of the trench is very, very important. So the importance of this I'm highlighting in this video. This is a mid-dilated pupil with a corneal scar in the opposite direction. I'm making a central trench. I did the trench, I felt it is adequate, but mind you, the nucleus is hard and the trench is only in the center, and that also is superficial. So I rotated the nucleus 180 degree, and I'm trying to continue the trench in the other direction also. The length of the trench has to be adequate. If the nucleus is hard, you have to make the trench till the periphery of the nucleus. Now, once you divide that part, again rotate 180 degree, make sure that the length of the trench is adequate in this direction also. After that only you should separate it. If your trench is not long enough and you try to separate in the center, you will never get the separation. You will end up in exerting more force on the zonules. So this is another case. It's a soft cataract with a NH2 nucleus. So you have to be very careful. The length of the trench is very important. In this, you have to follow the posterior concavity of the lens. So a deep central trench over 2 to 3 millimeter, and then 1 to 2 millimeter in the periphery. So you see, I'm trying to separate the trench, separate the two pieces, but I'm not able to. So what I do, I know that it's a soft cataract, so you have to go in the periphery beyond the rex's margin, and you have to be very, very careful. Your parameter should be low when you're going that, because this is away from the safe zone. The cataract is very soft. That's if your vacuum is too high, you might land up in rupturing the PC also. So the length is adequate now, and then you can divide into two hemispheres. So never be scared to make sure that your length of the trench goes beyond the rex's margin also. This is very, very important. Just don't be scared and be only in the central safe zone. Sometimes you have to be away from the safe zone also. Judging the depth of the groove is very important. How do we judge that? Always use low magnification. This helps in getting a stereopsis, and the depth of the field is maximized. The depth should be 2 to 3 needle width centrally and 1 to 2 needle width towards the periphery. Change in the red reflex is another very, very important sign. You will see the bright red reflex. That means your depth is adequate. The counter of the groove must approximate the posterior convexity of the lens. Therefore, the groove will be deeper in the center and shallower in the periphery. Never attempt to make a deeper groove in the periphery. If you are going to increase the length of that trench beyond the rex's margin, you have to make sure that you are superficial there. So coming to the cracking techniques, there are various ways of cracking this nucleus into two pieces after you have made the central trench. So in this, you can see I'm making the central trench. Again, always the trench. Now, I'm not going to teach you how to do the stop chop technique. This is a specialized course. So the trench is being made, but you have to make sure that the depth of the trench is adequate. In this, the length is adequate. I have rotated the piece into 180 degree. This is a long trench which I have made. But you see, when I'm going to separate this, it's not separating. Why? Because I am in the superficial part of the trench. I have not gone deeper into the trench. So if you're not confident, come out, put the visco, take two instruments, either two Sinski or a chopper and a Sinski, or two Sinski. Again, don't be superficial even if you're taking the two instruments. If you place the tip of this instrument in the superficial trench and you try to separate, it will never separate. You have to go deep into the depth of the trench as much posteriorly as possible, and then try to separate, and then you'll get a good crack. You see, I've gone deeper, and now you can get a good crack. And always make sure that the crack is through and through on both the sides. Otherwise, rotate the nucleus and then do the trench, and then do the crack. This is very, very important, especially when you're a lot of times this soft, cheesy cataract, it is very difficult to crack it. So you have to make sure that you do that. So in this case, the trench is made, but there's a lot of loose cortex which is coming. It is so sticky cataract, cheesy cataract, that you're not able to separate it into two things. The trench, the depth is adequate, but still you are not able to separate into two. So what you're going to do, don't be under the impression, no, I have to get a crack, I have to get a crack. No, the 4-quadrant technique is a savior. There's no problem in converting this into a 4-quadrant technique. So you saw I converted this into a divide and conquer. Now with the two instruments, I'm trying to separate. So even if you get one crack, one quadrant is separated, then automatically, because of the debulking of the nucleus, when you are doing the 4-quadrant technique, you get the subsequent cracks also, because there's space which is created and you have a lot of safe zone in this. So convert into a divide and conquer or a 4-trench technique if you in this type of situation, and now the pie can be taken out easily. So this is what I wanted to explain also about the cracking techniques. So the technique of splitting, as I told you, the splitting force should be applied at the bottom of the groove with the help of two instruments, using a direct or a crossover technique. So only when you apply the tip in the depth of the trench, you will get a good crack, otherwise you will never get a good crack. When you are not able to crack, then you should flip also. So basically, it is not a set technique, that I'm going to do stop chop in all my cataracts and I'm going to do that. No, you have to know how to deal with the situation when it arises. So this is a soft cataract. Basically, you have done the dissection. You should do multiple delineations also. Why delineation is important? Because when you're making the central trench, you can stay in the safe zone. Epinuclear shell is a protective shell. So when you're doing the trench, make sure that you crack the backbone of this central delineated area. You have made the central trench, you try to separate, get a crack, it won't crack. See, it is not cracking. So you have to go a bit in the periphery, and this delineated part you saw now, that has to be broken. The backbone of this nucleus has to be broken. Once it is broken, so only that, a small crack in that area is more than sufficient to enlarge the crack to the opposite side also. So rotate 180 degree, it is not cracking. So try to break the backbone a bit, and once it is done, you can either flip it by holding the nucleus, holding the hemisphere in the center, or you can just pull away one of the tip of the hemisphere and prolapse it into the anterior chamber and just emulsify it. So flipping of the nucleus also is a very, very good technique. It doesn't take a lot of phaco energy. It basically has a safety zone, and all these modern phaco machines, they are so very effective that you can handle any type of situation anytime. So again, this is a case, the picture quality is not so good, but you can see dissection and multiple delineations are done. The central nucleus is very, very hard, but the periphery, it is not, it is very cheesy cortex there. So trying to separate, we are not getting a good crack. I've rotated 180 degree. I'm trying to break the peripheral nucleus, the peripheral shell of the delineated area. See, once that is done, then you can prolapse it. So once it is done now, I'm trying to take out all the superficial cortex which is disturbing my view, and then you catch hold of this inferior part, prolapse it into the anterior chamber, and with the second instrument, just prolapse the whole piece superiorly, and you can emulsify the nucleus after that. You can see the nucleus is rotated up. With the second instrument, we'll just flip it off, and the whole nucleus will come into the anterior chamber, and you can just emulsify. The phaco-fluidics plays a very, very important role. If it is very soft cataract, your vacuum has to be low, your flow rate has to be low, then you'll be able to get a good crack and you can emulsify it. So when everything you have done, you fail. So how are you going to deal a situation? So this is a cataract. I'm doing my central trench. I thought it's a very easy, clear case. I can manage it. But as usual, you are trying to get a crack, but you're not able to crack. I'm trying to break the epinucleus bone, the peripheral bone of the delineated area, thinking that I'll try to prolapse it. But no, it is not cracking at all. It is not breaking. I then thought, let me try to again emulsify the backbone, but no, it is not happening. So now what we are going to do? The trench is quite enough. I'm away from the safe zone. Now I'm trying to chop it by thinking the central nucleus will act. I can do a direct chop, but no, still the hold is not adequate. I'm not able to do the chop. So what has happened? You have tried stop and chop. You have tried the direct chop. And now in the central nucleus, once the central groove was made, that support was there of the hard nucleus, and I was able to get one small crack. So once that small crack is done, emulsify all the superficial cortex which is there. A thin plate is left behind like a saucer, and this saucer can be tumbled up, or this saucer can be just cracked in the center itself, and then you can prolapse into the anterior chamber. So a lot of mix and match of techniques in this case. This is because you should know how the cataract comes, because all cataracts are not the same. You have to tackle the situation as in when it comes. So thank you. Now I request Dr. Krishna Prasad Kudlu to present his talk on in his direct chop, when he's not able to get a crack, how he's going to deal with it. So Dr. Kudlu runs a fellowship program and a training program for phaco and LASIK and refractive surgery and smile at his center in Udupi. He's a member scientific committee. He needs no introduction. Over to you, Dr. KP.
Can I have the mic on? Okay, thank you so much, Amit, for including me in one of the very important instruction course. Probably, I think, even I too learning in every talk. So my talk is today about struggling with the direct chop, not able to crack, how I deal. So let me, excuse me. Yeah. So let me come directly to the direct chop. The idea behind the direct chop used to use a chopper, that is the mechanical device, to divide the nucleus into the halves, further into the smaller fragment. So what exactly happens within the chopping technique? It utilizes the manual force to crack the nucleus with phaco power, being which has been utilized only to obtain the hold the nucleus. So there are two types of chopping is there. One is vertical chopping, second one is a horizontal chopping. Why we are not able to crack? I think already Dr. Amit has shown his lot of videos for stop and chop. Why you are not able to crack for direct chop? Because sometimes if you do a small rexis, in case of a hard cataract, small pupil and soft cataract, these are the condition where you will not have the direct chop. So what are the technique issues can happen? One is improper hydrodelineation and improper hydrodissection, improper phaco technique, putting a wrong phaco power for that particular case, the type of chopper what you use, whether it is a sharp or blunt, regard the type of cataract, and once again, size and exposure of the phaco tip, angulation of the phaco tip is also very important, and lastly, important about the what phaco mode you kept for that particular case. So coming to the incomplete chop, so what exactly is this? Failure to divide the nucleus in the first chop, that occurs due to always superficial location of the phaco tip 1. Then you can try it with the one more time. However, if you do several times, what will happen? The central mass will decreases, making it more and more difficult to have a good grip. The sharp point of the vertical chopper sometimes may tear capsular axis, but if you strain the capsule with the Trypan blue, I think you can come out with any of the further complication. This is what it will happen with the incomplete chop. If you take a chopper, blunt chopper, try to chop more superficially, because I have seen youngsters, fellows, they try to do the chop, but they are very hesitating to go underneath the nucleus. They try to do superficially, then you may land with the incomplete chop. So let me come to the horizontal chop, which has been described by Nagara in 1993. What he has done, nucleus is divided into the two fragments using a chopper which is moving in a horizontal plane. After being placed at the equator under the anterior capsule, the chopper moves towards the phaco tip, which has impelled in the center of the nucleus. When the chopper reaches the phaco tip, both instruments are like what Amit showed, instruments are moved apart, leading to mechanical division of the nucleus. I'll be showing the video in the end. So coming to the horizontal chop in continuation, normally the nucleus is secured between the chopper and the phaco tip, so less depend on the vacuum level. Very important when you're doing a horizontal chop, especially more prefer to do a much softer cataract. Rexis has to be at least 5 mm. Adapt sleeve perfectly in the incision. Exposure at least 1 mm of the tip. Chopper of at least of a size between 1.25 to 2 mm. Place the chopper in the bag, lens equator opposite in the main incision. This is very, very important. So coming to the impel the phaco tip, start stabbing the nucleus from the proximal edge of the capsular axis, pointing toward the nucleus center. The main thing is you have to keep a high vacuum with the flow rate. Either you can go with the pulse mode or the burst mode, the ultrasound which is preferred one. Once the maximum prefixed vacuum is reached, the tip of is occluded, the foot pedal is changed to position 2. This is very, very important. So the chopper is moved towards the phaco tip until they are closed. The instruments are pushed apart laterally so that the mechanical division of the nucleus will happen. Then you go ahead with the subsequent division, that is progressive rotation of the nucleus, what Ami showed in his video, so that the face of the fragment should be impaled is parallel to the transverse surface of the phaco tip. The harder the nucleus, smaller fragments you will get, consequently higher number of the fragments. So your chopping has to be very good. So this is what we do. See, this is a blunt chopper, but it's a long tip one. So once you take out the whatever the loose cortex over the nucleus, so as I said, that proximal end of the capsular axis behind, it has to go inside. Then you go inside the nucleus. Make sure that you are going in the right direction. As you all know that the center nucleus is very thick. Go from the periphery, come towards till the tip. Now you chop it. So the mechanical force has to be equally together for the horizontal chop. So you go like this. Now you can chop. Always like I love to do 5-6 chops together and make it finish, because sometimes see there is a always you can see this in this particular case the nucleus piece is going around, then it may touch the endothelium, you may land in problem. So better is you do 4, 5 or 6 minimum horizontal chop, then you can have the complete the phacoemasculation. So what are the common complications you can have when you are doing a horizontal chop? Then is one is incomplete first chop, generally caused by a superficial localization of the tip, as I already told. So you can try once again new chop there. If you are having a zonal dialysis because of the improper location of the chopper over the anterior capsule, this can also happen. Then but you can saved by the trypan blue, you are already been straining. Suppose if you can have the capsular tear also, not to become panic. I will not talk about you how to manage with whenever you are having a capsular tear. So in such cases, if you are already strained with the trypan blue, you can come out with the cases. So coming to the vertical chop, here what happens, the chopper and the phaco tip move towards each other in the vertical plane, inducing a shearing effect. Unlike horizontal chop, during the vertical chop, opposing forces are created that never trap the nucleus. It relies on the high and consistent level of the vacuum while the nucleus is being divided. But here, compared to the horizontal chop, as I said that their minimum 5 mm rexis is required, but here even smaller rexis also you can do the vertical chop. So rexis size is not determinant, but always when you're doing a vertical chop, prefer to do for a very hard cataract. So I prefer to do a very sharp chopper, always which is more than 2 mm. So in continuation with the vertical chop, normally the embedded tip deeply into the center of the nucleus without going beyond the proximal half of the nucleus. This is very, very important. Once the phaco tip has reached to the desired depth, has become occluded properly, now the foot pedal is held in position 2. You stabilize the nucleus. The movement of the chopper creates downwards a vector action that opposes upward force that induces by the occlusion, so that the nucleus can be disengaged from the phaco tip. For this reason, achieving a proper occlusion, high vacuum is very important for this vertical chop. So I'm just showing you patient with a grade 4 cataract. So nowadays the concept has been changed. You can have a straight tip, bent tip or Kelman tip. Only thing is, so how you hold the nucleus is very, very important. Go within exactly in the center, embed the nucleus properly deep into that. The very sharp chopper, try both the forces equally towards, then you can chop it properly. So once this crack over, I think most of your job is done. Then you can rotate the nucleus with the help of the both chopper and the phaco tip. Then you try to chop into different. So whatever the grade of the nucleus, if your chopping technique is very good, still you can come out with the perfect results. Once again, appropriate selecting of the chopper is very, very important in pertaining to that particular case. So let me come to my final part, which is choosing a best technique. Whether horizontal or vertical chop does not make a great difference of difference. Therefore, surgeon should use one which he is more familiar. That is very, very important. Even a lot of my very close friends, very hard cataract, still they do a horizontal chop. Even my friends chopper, I think the Rajendra Prasad will show his chopper. It more uses with the horizontal chopping, but the chopper is something different. It has got a sharp edge within the chopper. So if you got such chopper, I think you can do even a horizontal chopper, even for a very hard cataract. However, a variety of cases in which one technique may sometimes superior to another. What I do, I'm just sharing you. If I do a small capsular axis, I do a vertical chop. Deep and deep anterior chamber, always I prefer to do a horizontal chop. If I am finding that there is already zonular weakness is there, either I will do both vertical or horizontal. My preferred one is horizontal. If I am having a small pupil, I prefer to do a vertical chop. If I am having a very hard Brownian cataract, my preferred technique is vertical chop. In conclusion, angulation of the tip makes direct chop easier, especially with 0 and 15-degree tip. With the proper maneuvers applied, appropriate cases, phaco chopping techniques can lead to a good outcome in a cataract surgery. The basic principle benefits are reduction in the total ultrasound energy is our goal, and phaco emulsification time also, and also which decreases the stress on the zonules. Once again, I thank my friend Amit Porwal for this wonderful opportunity. Thank you one and all.
Thank you, Dr. KP, for this wonderful video illustrated talk. Before you leave, just a couple of suggestions and opinions from your side. So first, from the audience, do you have any questions for this? Please come to the podium and put up your question. We have kept ample amount of time for discussion so that we can take up your difficulties. This is a very designated course which has to answer the queries, the minute queries which a delegate will have. Any questions from the audience? Okay, KP, you have been into fellowship programs and cataract training programs. So the most common, I also do the same thing. I run the cataract training program at our hospital also. The most common thing what I realize is people are scared to use a chopper. They still want to use a dialer and they want to do all the chopping techniques with the dialer, which I always tell my students, use a chopper. Start with 1 millimeter, then 1.5, then 1.75. Start with just a round tip chopper, and then if you want, you can go with a double-edged chopper also. So what is your opinion? Should we tell them to start with the chopper straight away, or should we tell them to practice with the needle dialer only?
In my hospital, I run both PG and fellowship training program. What exactly we do, first, whatever you showed, we tell them to start with the stop and chop. But even they start with the stop and chop, we start with the blunt choppers initially. That is the round tip in front. So once they are okay with the round tip, then we will tell them, you start doing the stop and chop for another 50 cases. Once they're 50 cases over, I'll tell them with the same chopper, they have to divide on 51 case onwards. There only with the stop and chop, which is converting to a direct chop. Once they are familiar with the direct chop, still I'll tell them to go ahead with the blunt chopper. To tell them to train for a horizontal chopping, I'll tell them to start first. So they have to learn first horizontal chopping. Once their horizontal chopping is done with the blunt chopper, then I will tell them, now you take the sharp chopper. Take the sharp chopper. Once you take the sharp chopper, I will not tell them to go with horizontal. Sharp chopper is exclusively for vertical chop. Then they have to try, we give them around grade 3 cataract, because suddenly if you give them a grade 4 cataract, these fellows, that they become panic. Give them a grade 3 with a sharp chopper, suddenly they feel very nice. The nucleus embedded and the equal force is divided, then they can come out with a good result. That give them the confidence. So what we train fellows, what we train PGs, I think the initial training is so key to make them the best phaco surgeon.
KP, I think we have a question there. Yeah.
Tip, which tip do you prefer, sir, for beginners?
So again, it depends on what phaco machine you have.
For basic machine, compact?
15 degree. The tip actually, if you ask me, 30 degrees for beginners is a fantastic one. But nowadays I change, like for beginners, tip matter, I will not matter anything. Your chopping technique, I personally feel it matters. Of course, for beginners, if you ask me 30 degree, even 45 degree is not a bad option. But 30 degree is ideal one, but we start with a 15 degree tip.
So let me answer your question in this way. You told you have a basic phaco machine, so it is very difficult to get a Kelman tip. So if you want to do the stop chop technique or a divide and conquer technique, ideally what KP told, 30 degrees is the best because it allows you to make the trench also and it allows you to do a chop also. But if you're already well versed in that, then you should have the second tip, that should be 15-degree tip. Because 15-degree tip will help you in your direct chop and the horizontal chop. As you advance in your chopping technique, the aim is to reduce the phaco time. So you should have both the tips. 30-degree ideally, which can give you the central trench and you can chop also, but direct chop is your main aim, then you should have 15-degree because you'll have good hold. I won't say 0-degree because 0-degree then it will be only helpful in chopping. You will get very good hold, you will be able to chop. But then sometimes you need to make the trench, sometimes you need to go to the other planes, you have to rotate the phaco probe and you can emulsify it because followability will be there. So I would adequately recommend you 30-degree and 15-degree.
Stop and chop, initially start with 30-degree, then you can, for converting, then you switch it to 15-degree.
And always
that really makes
make sure KP starts with stop and chop. I follow the rule book which says at least 25 cases divide and conquer, then next 25 cases stop and chop. Direct chop only if you are confident in your stop and chop technique. If you are still not confident in your stop and chop technique, never attempt direct chop. Because direct chop has its own set of complications. You should have good hold on your equipments, on your hand. You should be focused in the microscope. You should not be focused only at the tip and the second instrument. The whole eye as such, you have to focus it so that you know where you are touching. Well, any other question?
Thank you, sir.
Thank you, Dr. Amit. Yeah.
Hello, sir. Sir, you told about the settings for the chop setting. No? So once the fragments are made, so we have to remove the fragments. No, that time any change of settings you are suggesting, or same setting you can continue. Like
See,
change
once
to pulse
again,
mode
depending upon the surgeon's confidence, you can lower all. Once the chop is over, you can once again you lower the settings by, you can reduce the vacuum also. Even if you think that the power, like the nucleus hardness is lesser, then you can even reduce the power also. Once you are in that motto when you're doing, normally the mindset will be for that particular setting, let us finish the case and you come out. That's what we do. But there is nothing wrong. You can even reduce all the parameters also. It makes sense.
So basically for the last fragment, you should reduce the settings unless and until you are doing all on the, you have the linear control of all the parameters. So I use linear control in everything. So I don't reduce my setting at all because my foot coordination helps me in reducing all the settings. So this depends on your parameters, how comfortable you are.
And for last piece, even in our phaco training program, for last piece, immediately we reduce everything, make sure that only with the flow rate they should be able to clean it without almost zero power.
So as you go on increasing your number of cases, you will realize the importance of reduce the settings, epinucleus mode. You realize this importance, that how helpful these settings are. So either a good control on your foot switch with a linear control, you can reduce the parameters, or have your parameters set, chop mode, quadrant mode, then epinucleus mode. So epinucleus mode is the last piece and the whole epinucleus shell.
Even the times the second instrument can be changed from chopper to dialer also for the safer side.
Yeah,
for the
that's
beginner.
true.
Thank you, sir.
Thank you. So we'll move over with the next topic. This is by Dr. Rajendra Prasad, the none other than the innovator, the inventor of the terminal chop, and his second name is the Terminator, because that terminal chop technique, what he described, it has helped a lot of people in handling the hard cataract. So now over to you, Dr. Rajendra Prasad. He's going to talk on while chopping when the cataract doesn't crack, what to do. This is the name of the IC. Your topic, please.
Good morning, friends, ladies and gentlemen. First, I'd like to thank Dr. Amit Purwal for keeping me and giving me this opportunity to be here with all of you in this beautiful morning in Kochi, the beautiful place also of Kerala and almost definitely of India. So the topic which I'm going to talk about is while chopping, when cataract doesn't crack, what to do. You have seen Dr. Kudlu's presentation. Most of these techniques he has described very beautifully here and to all of you, and explained each and every step. So I'm going to take you on a little different side of the cracking the nucleus. Friends, you know that these mature, hard and rock-hard cataracts have always been a problem to all of us, and they present series of specific and difficult challenges, starting from the capsular axis, to the nuclear segmentation. The biggest challenge they present to us is they don't crack easily. So we use different techniques, the horizontal, vertical, lateral, proximal, all these chops we have been using, but most of the time with the beginners especially, because they don't crack, and then we land up into the problem. The biggest problem, what happens, because the topic also includes the free-floating nucleus. If you have a free-floating nucleus, the biggest problem comes up, the holding the nucleus and how to crack these free-floating nucleus, especially in the Morgagnonian kind of cataract. So here you can see this Morgagnonian cataract, the capsular axis has been completed, but as you see, the nucleus is almost floating in the anterior chamber, in the capsular bag, and the problem comes up how to hold this nucleus and how to go about cracking this nucleus, because you cannot do the horizontal chop, you can't do the vertical chop, you cannot do the trenching in these kind of nucleus. So it becomes so difficult to hold and crack this nucleus. The other techniques like we are using the horizontal chop, many times when you're using the horizontal chop or the vertical chop, you don't get the complete crack. Many times you are left with the posterior plate or incomplete segmentation of these nuclei. Whether you use the blunt chopper or you use the sharp chopper, as I am using the sharp chopper in the second case to do the vertical as well as the horizontal chop, but you don't get the crack actually. So you may get the crack, but many times the cataract is leathery, very hard, then you don't get the crack. As you can see here in this second video, you go ahead, hold the nucleus from the center, you're going to do the horizontal chop, but then finally you don't get the complete cracking of the nucleus. You try the vertical chop, you are not able to penetrate even these sharp choppers into the nucleus. Try to penetrate, you don't get the crack. Then what we do normally, we go ahead with this hybrid technique. You start trenching at the center, make a plus sign, deep trenching. You have to use a lot of physical energy, a lot of manipulation. It takes too long to do this kind of procedure. And then finally, you are left with using very high CD value, and many times the shear rupture forces are used. So you get many of these complications during the surgery. So one of the biggest study done by the Maleka Hospital, they have done almost 14 to 15,000 cases of study, and they found that most of the complications in hard cataract happens during the nuclear fragmentation and also during the nuclear emulsification, during the rexes, and even during the hydro procedure. You get many of these complications. And the most commonly come across complication is the PCR without lens fragment fall, and PCR with jonular dialysis with vitreous loss. So these are the complications we have seen, because I have seen in many of my cases in the beginning happening these complications. So what to do then? The answer is go around the equator of the nucleus. So this is the technique which I'm going to talk about. Go around the equator of the nucleus to crack this nucleus. Take your chopper around the nucleus and crack. So how you go about? See this free-floating nucleus which I showed you in the beginning? What you need to do is just hold this nucleus firmly at the center, penetrate your phaco tip into the nucleus, take the chopper around the nucleus, and then crack it. If you don't go around the nucleus of this kind of nucleus, you won't be able to crack, because you cannot do the horizontal or vertical chop in these cases. You have to go around the nucleus. Then only you can crack these nucleus. Once you crack, then you can start emulsification of the fragments very swiftly and very easily. So what is important in this situation is the selection of your chopper. Dr. Kudlu described many of these choppers, which I am showing here in this figure. The important point in selection of the chopper is your chopper has to be designed in a way to protect the posterior capsule. It should prevent the nucleus rotation. It should hold the nucleus firmly while cracking. It should crack the nucleus with fracture force, not with the dispersive force. It should crack the nucleus with the fracture force. And it should be ambidextrous, like you should be able to use it right and left hand. So the important point in the chopper is the shaft length, the angulation of the tip, the tip slip, and the edge of the edge of the tip, the inner edge of the tip. So I'm going to show you one video, a small animation video of the triple edge wedge chopper. So this is called as triple edge wedge chopper, where a wedge is incorporated within the inner surface of the chopper. And you see the kind of the chopper. The tip of this chopper is olive tip. It's round. So when you are hooking the nucleus, when you are doing the horizontal chop or any chop, this is not going to threaten the posterior capsule in any way because the tip is round and olive tip. You see the inner edge. The inner edge is wedge shaped. It's a wedge. So when wedge goes into the nucleus, it gives you a cracking force, not the cutting force. It gives you a cracking force. And it has a triple edge. You can use it right and left hand in any way you crack the nucleus. So what happens, these wedge choppers, it's a basic physics. Like when wedge enters into a hard object, it converts the radial force into the transversal fracture force. As you can see here in this figure, when you take the force this way, this force is converted transversally. So when this force is converted transversely, you get a fracture of the nucleus. So you don't have to do too much of manipulation. You don't have to do the lateral separation force or so, because this wedge itself gives you a fracture force and your nucleus start cracking. Now this device is named with my name, Rajendra Prasad's terminal chopper, and it's also called as a terminator, this device. How to use this device? So you can see here in this animation, you have to penetrate the nucleus from the center, go towards the equator, hold the nucleus firmly, and then this device, you have to pull the nucleus slightly and see the edge of the nucleus like this, and then go around the nucleus, fix it, and then slightly push inside, and you get a crack. And you get this kind of full thickness crack. And the important point here is you get a full thickness crack. You will be never left with the posterior plate. Your crack is going to be complete through and through, and most of the time crack extends from one equator to the other side. You get a 2 heminuclei. Then you can go ahead to make it 4 pieces or 6 pieces. This is the kind of split you get. This is our publication of this terminal chop. And I'll show you some simple videos. You can start using this technique even in a grade 1, grade 2, grade 3, grade 4, up to grade 6 nucleus also. The beginners can use this device in a grade 2 to grade 3 nucleus. And you can see this is grade 2 nucleus. Just hold the nucleus, go around and see the crack. This is the crack you get. You don't have to do too much of manipulation. It's so simple. Hold the nucleus, draw it a bit, see the edge, hook it, and you get a crack. See the crack. It's a very simple technique, very, very simple technique to fracture these nuclei, starting from grade 2 to grade 6. Now see, this is grade 3 nucleus. Hold the nucleus, go around, and see the crack. You get a full thickness crack, and you will be never left with the posterior plate. It's going to be a complete full thickness crack. And this cracking, if you are able to do the cracking of the nuclei into this kind of fracture, then your rest of the procedure becomes so simple, because you can then play within the capsular bag once you get the complete fracture of the nucleus. The first fracture of the nucleus of these kind is very, very important. This is grade 3 nucleus, a slightly harder. And I'll go ahead with the grade 4 nucleus. See the grade 4 nucleus, hold it, go around, hold it, go around. You have to hook it completely. Hook it, and then see the crack. This is the slow motion I've shown you. Crack and full thickness. This is grade 4 nucleus again, a slightly harder, and see the crack. Full thickness crack. Go ahead. 1 more minute. Yeah. And this is grade 5 nucleus. Go around and see the crack. This is the crack you get. Now what happens actually, because when you are doing this technique, you have to do a good preoperative examination. You must have a well-dilated pupil. You must use maximally retentive viscoelastic, soft shell technique or tri-soft technique. You should have these devices with you always. Do a good capsular axis, stain the anterior capsule well, and do a good capsule. Your capsular axis has to be complete. And even this kind of nucleus, this is the grade 6 cataract at Niagara. I'll just show you one chop of this nucleus. You hold this nucleus, go towards the equator, hold it firmly, go around the nucleus. And in this kind of nucleus, you may have to use a little bit of lateral manipulation, but still you get a complete full thickness crack. So to conclude, this device is the simplest device. Threadless, you can crack any kind of the nucleus, and especially the hardest of hard cataract, rock hard cataract, you can crack. The harder the nucleus, this device works better. Harder the nucleus, it works better because it gives you a fracture force. So your fracture force creates the complete division of the nucleus. So thank you very much, and I'll complete my presentation with this.
So we'll take questions regarding this talk after Dr. Jeevan Tityal sir's talk. Dr. Tityal sir needs no introduction. He's the chief of RPC. He's authored many books. He's got numerous publications. And his favorite topic, posterior polar cataract. So he's going to deal on how do I deal how in posterior polar cataract, when I'm not supposed to rotate, how do I deal or crack this? So over to you, sir.
Thank you, Amit, for a kind introduction and inclusion into this instruction course. We all do difficult cases, and posterior polar is one difficult scenario where things cannot be, as simple as possible, because sometimes you have an open posterior capsule, and we classically teach the posterior capsule can open up anytime during surgery, and you have to manage. The teaching here is avoid hydrodissection, avoid cortical clinic hydrodissection, avoid nuclear rotation. Then how to do a safe emulsification in these cases when you only done hydrodissection, hydrodelineation only. So that's a challenge normally seen in a slightly harder nucleus. Soft cataracts, you can do a beautiful delineation and leave the cushion behind and do a complete surgery in these cases. Therefore, the nucleotomy becomes challenging in all these posterior polar cataracts, and that may be the cause for sometimes dialysis happening and drop happening in these cases. General disruption, nuclear drop is a problem here. So once we avoid cortical clinic delineation, we have to do a safe nucleotomy in these cases. Like this is a delineation I've done. First delineation wave, second delineation wave, and this is how you're going to approach these patients. You can see this is the separation of endonucleus from the epicortical cushion seen on an IOCT microscope, and you can see the golden ring area. This shows that you have done a nucleus delineation appropriately here, no hydrodissection. So these cases are difficult to rotate. So how do we proceed in such cases? After we've done a capsular axis in these patients, I'll do a little trenching in the center. You can see a trench being done here, so that we can have a good hold here. So do one chop here. So this gives a space here, because nucleus cannot be rotated because delineation is not complete here. Take another pi of a piece here. So this is going to create the space here, and this space will allow the fluid to seep in. Take another pi from left hand side, and you have a triangle which is open now. Now you can tumble the nucleus back here now. There's no rotation being done here. This is a chop and tumble. You can see here, now this piece can be just pulled up to the center. You have seen that there's no disruption of the epicortical cushion here. So that's the importance of posterior polar cataract. Now you can take out the epicortical cushion, pull from the periphery, leave it to center, pull from the periphery, leave it to center, then pull it in bulk. In that way, even you have a tear, you'll not have a problem here, because nucleus is taken care of, and epicortex is also taken care of. Now you have an open area, which is a clear posterior capsule, and you can easily do complete surgery in these cases. Just to highlight the same feature here, posterior polar cataract, I'm doing the same technique here. One pi, second pi has been taken care of. You can see the IOCT microscope tells you that this space gives you a space for a fluid to seep in. And there's an inner hydrodelineation, and multiple layers of delineation has occurred because of this chop pattern in these cases. So always, not only posterior polar cataract, you have a subluxated cataract, you have a difficult case where you could not do a proper hydrodissection. This is a technique of nucleotomy which will help you. Tumble the nucleus back into the center area. This, you can see this pulling of a nucleus towards the center will not allow the disruption of epicortex. So this is the second instrument pulling the entire area towards the centripetally, and you can manage very effectively in these cases. So this is how you're going to avoid rotation of nucleus in these cases. Now, if you have an open posterior capsule, again, this technique is going to be useful here. So this is one case of typical posterior polar cataract. You can see an onion peel technique with multiple layers. And if you see the IOCT also, the posterior capsule delineation is very difficult in this type of posterior polar cataract. You can see everything is shadowed here. You do a nice capsular axis around 5 millimeter, do delineation here also. And during this delineation, you can see, just see here, the flutter happening. That indicates the posterior capsule has given way at this stage of a nucleotomy, before nucleotomy, nuclear delineation. Same technique I'm going to use. So this technique also useful in those cases where you have a pre-existing defect or you have created defect during hydro procedure itself. Take out those pio pieces. Now we'll tumble the pieces to the central area and complete nucleotomy here. Then take out the epicortex safely, and you'll see that posterior capsule was open before I could initiate the nucleotomy. You can see a central opening here. This is a typical posterior polar opening in these cases. Just before come out your second handpiece, always plug the opening with a dispersive viscoelastic. Do a bimanual aspiration of a remaining cortex. Fill the chamber with the dispersive viscoelastic. Now put little cohesive. In larger incision, inject the IOL over the rhexis. Don't inject inside the rhexis. Now you tuck the haptic under the rhexis, and this will not disrupt the opening here. So you have an intact anterior face of vitreous, and the tear has not opened up. The idea here is to do a safe nucleotomy and inject the IOL in safely, and can still manage the IOL in the bag in such cases also. So this technique of chop and tumble is very helpful in cases where you have a nucleotomy when rotation is not required. Same thing can be done with a femtosecond laser also. This is our technique where we do a multiple rings of, you can say, laser delineation and multiple chops, which gives a block of nucleus. You can see here, this is a chop here, no hydro procedure done. Open this chop, and you release the pressure from behind. And you can take block by block pieces of a nucleus. So this is a primary block I'm taking out, the first layer. Then I'll go to a secondary layer of a nucleus fragmentation. You can see I'm taking out the second layer now. No rotation required, and each pieces can be taken out separately. So sometimes femtosecond laser is very, very helpful in these type of cases to safeguard your cases of posterior polar cataract. Thank you. I hope that this chop and tumble technique without rotation will help you in managing posterior polar cataracts. Thank you again.
Any questions? Because sir is going to leave. Yeah, please. Because he's got multiple phone calls. So any questions? Just a quick reply so that doubts can be cleared.
About posterior polar with a hard nucleus.
Yes, sir. In hard cataracts, again, same technique may be useful, because I can understand, if you have not done hydrodissection in hard cataracts, then the entire nucleus, pulling and cracking will be difficult there also. There, you have to do a multiple, layers of sculpting, make a crater, and hold the piece in the periphery. This is making a grade 4 into grade 2, 3, because central core is the more hardest. So if you can debulk the central core, you can easily chop subsequently, and same technique will be useful in those cases also.
Thank you, sir. So before we end the IC, we have one keynote address by my friend Dr. Anurag Mishra, a great cataract surgeon in whole of East India, and he's going to talk on the brighter side of new generation microscope. So till Anurag prepares, Naren wanted to share his view on the question which was asked.
Yeah, see, I think that's a very valid and good question. See, what do you do when the sclerotic part of the cataract is more? When it is a hard cataract, you cannot do a hydrodelineation. It becomes a big, big challenge. Actually, these are the candidates where femto cataracts are amazing, because the femto itself will create a hydrodelineation for you. So it becomes so much more easier to do the surgery. This is the only scenario where it's a clear-cut femto is a very, very superior, plays a very superior role in very hard cataracts, where the sclerotic component is very more in a posterior polar cataract, I would say, yeah.
Naren, but I think the majority in the audience won't have a femto. So what message do we give?
So the message is very simple. Do not, anyway, you can't do hydrodelineation, you can't do hydrodissection, do not worry. What you need to do is, without rotating the lens, you need to do chops. In the sense, the first chop, what you have to do is, you direct your phaco tip maximum as much as possible to your right first, okay? Then do your chop, then again tilt your phaco probe straight, then do one more chop, so one piece gets free. Just remove that piece. Then again, tilt it again, take the next chop. So what's happening, you're chopping piece by piece. By the time you finish removing two pieces, actually the rest of the piece also become little loose. But these are the cases where there's a high chance of the PCR. So always remove. Do not try to chop all the pieces and remove after you finish chopping. Always remove one. Once you finish one piece, remove it. One piece, remove it. So that what will happen is, if there's a drop, at least, or if there's a PCR or something like that, you can at least prolapse it and take it out. If there are too many pieces, there's a chance of one of the pieces to drop. So I would say this is the best technique.
So multi-level chopping, what sir told, is the best. And what Naren describes, you separate one pie in the periphery. What Dr. Meenu was talking about, the peripheral chops or the flower petal chops. So one quadrant in the periphery, if you have chopped, just pull it up a bit, go behind with the chopper, go behind the piece, disengage it, so one pie is gone. So you can try with the inferior half like that. So once inferior half is emulsified in these posterior polar cataracts, which are hard, with a hard nucleus, inferior part is removed basically, the superior part is there. You have to tilt the phaco probe and go towards the other part and just pull it up. So a lot of times this intraoperative maneuvers will be different, but multi-level chopping is the key in these patients. Yeah.
My question to Dr. Rajendra, you advise in the case of a small pupil terminal chopping, you can advise on a small pupil and a small capsular axis.
Small pupil and a small capsular axis, you said, no? So that's why I said very clearly, because whenever you're dealing with any hard cataract, whichever technique you are using, whether terminal chop, horizontal, vertical chop, you have to have a well-dilated pupil. That is very important for hard cataract. If you don't have a full dilated pupil, then you can use the devices to expand the pupil. You can use hooks or rings, whatever is available with you. I showed you in the last that these devices you should be ready with in your OT when you are dealing with the hard cataract. You have to have a full dilated pupil. Your capsular axis has to be minimum 5 millimeter. It should be preferably around 5.75 millimeter. Axis is the best in these hard cataract, because even if you are able to chop with a little smaller axis, your manipulation becomes very difficult if you don't have the good size of axis. So that is ideal. But yes, if you have a little small pupil or a small axis, still you can do the terminal chop, because in terminal chop, what you are doing is you are not actually blindly going underneath the capsular axis to the periphery. Here what I said was, when you hold the nucleus, you slightly draw it. You're drawing. So while drawing, the nucleus moves vertically. So you, even a little smaller axis, say around 4.5 to 4.75 millimeter axis, you can still see the edge and you can hook it. The same with the pupil also.
Another thing, I saw your video. Your tip is more superficial than usually I'm using the
tip
chopping. More superficial on the nucleus. More superficial.
Most? Your voice is...
Superficial.
Phaco tip.
Phaco tip.
Yeah, it's not superficial. Actually, we are actually entering from the center, because you see the nucleus, the shape of the nucleus, it's convex posteriorly. So if you are going directly deeper, you're going towards the posterior capsule. What I tried to say was, when you enter from the center, don't go deep, you go little superficially, not deep or one, little superficially towards the periphery. Because in the periphery, the nucleus is thin. If you go deep, you may hit the posterior capsule. So you have to keep it straight, because you have to go towards the equator, then only you can move the nucleus easily. If you keep at the center, then you are going to put the stress on the zonules.
Thank you, sir.
Yeah. So, Dr. Anurag, are you ready?
Already talked to Dr. Sethi.
Just 1 minute, please.
Very good videos on by Dr. Sethi. But usually we know in the soft cataract, all parameters should be lower side.
Yeah.
I saw his video, vacuum was more than 650. Flow rate is around 50, 60.
Yes, sir. So the thing is, I think we have always been taught that, okay, we have to soft cataract, we have to lower parameters, make it low vacuum, low flow. Actually, we should do reverse. Why? Because, see, anyway, to chop really a soft cataract, it's more of a mechanical. You're not using your vacuum and flow. The vacuum and flow is to remove the material. That's all. It is not for chopping. So chopping is more of mechanical. Usually is done under irrigation. So once you have chopped, when you have high flow and high vacuum, what happens is the pieces come instantly and you finish so quickly. You saw in those videos, right? Just happens so much more easier. It's not about I'm doing it for just to give a challenge to myself. No, actually, it's making my life so much more easier. So, but what is very, very crucial is whatever settings you're using in your machine, it has to have a stable chamber at the end of the day. Simple. That is the rule. You use high settings, it has to be stable chamber. If it is not stable, you have to reduce according to your machine performance. Definitely. Thank you, sir. Thank you.
We'll start with Dr. Anurag's keynote address.
Thank you, Amit. Good morning, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. Now, if this is how an active but non-erupting volcano looks from up top, and you would like to mirror that same imagery into the eye when you're trying to look at the eye in question or about to be operated by you under the microscope, there's no reason why you should not be calling this as volcanoculus. And volcanoculus is kind of a feeling which is offered to you by this specific microscope which is in question. And I would just like to run you through the next few minutes this spectacular instrument which I've been using for the last so many months, and I've been extremely happy with it. It's called Luxor Revalia, and it comes from the house of Alcon Laboratories. There are very specific numericals or dimensions to this device. It produces advanced visualization and personalized illumination. This is something I love about this machine. Normally in microscopes, what you have is two types of illuminations. One is oblique, the other is coaxial. But you do not have the liberty to change each of them individually and bring in a balance which works for you the best. Let's look at the fact that do we need both oblique and coaxial illuminations at all, because we know that the coaxial illumination is what produces the red glow, and essentially the red glow is essential for all of us, for all of the surgeons to increase the workflow efficiently. There's no doubt that coaxial illumination is ideal for helping you to see the reflective or mirror-like objects, and it provides you an excellent background against which you can do your proper capsular axis. However, the oblique illumination is also important because it is ideal for helping you to see the transparent or semi-transparent structures like the cornea, the sclera, or even the posterior capsule. So what happened with the earlier platforms was the moment you increase the coaxial, the oblique automatically goes down. If you use 100% coaxial illumination, it provides excellent red glow to you, but it goes down on oblique illumination, which essentially drops the depth of focus as well. This is one instrument where you can actually adjust both of them. So this is the kind of illumination it produces. The red glow comes from a divergent type of separation that happens from the light source, and that's why you have a very wide red glow. We'll see examples of that in a moment from now. This is the other USP of the equipment. The objective lens is placed above the illumination source. So you have a buffer of 65 millimeters. Believe me, if you focus on the cornea, it shows you right off the posterior capsule. You don't need to go up and down with the foot switch, adjusting the fine tuning of the microscope to see any structure at all. We'll see the example of that in a moment too. It produces a very functional screen, the best screen that I've seen in a microscope at least. It gives you the liberty of adjusting the illuminations all right, but it has an inbuilt recorder as well and an inbuilt parameter projection. So you don't need to have a separate video overlay or a separate recorder. It does everything for you at the click of a button on the foot switch. So the surgeon decides when to start the recording and it clicks on the foot switch, and I've not seen this again in any operating microscope till now. Very functional foot switch as well, 13 functional switches. You can adjust to different settings, but I'm not a very fan of using the microscope foot switch too often. So that's why this machine actually helps me in focusing at one area and seeing the whole through. These are different settings. In the interest of time, I'll not go into the details of that. And you can customize all the settings that you want in terms of illumination and focus and magnification and save it against your name, just like you do in the phaco machine. So you've got the advantage of memorizing 6 profiles, and you can just click your name and all your preferred settings do come on the microscope. Very essential for a center which employs multiple surgeons. So the USP of this machine would be something that we'll see in the form of a video. This is one capsular axis being done in a pretty dense cataract. The microscope that is used in this case is the previous platform that I was using, and that was an industry-leading equipment in producing red glow, and it had actually popularized the concept of a brilliant red glow against which the axis can be done. However, what you can observe in this video is the moment the eye is shifting or the moment the hand is shifting, you can see a difference in the brilliance of the red glow. It's not uniformly brilliant. There's one sweet spot where it is maximally brilliant, and if it is moving hither and thither, the brilliance tends to go down. Nothing probably much to disturb you as a surgeon, but still, would you not like to have a brilliance that is equivocal across the movement of the globe? Let's look at a similar grade of cataract with the Revalia. Now you see, intentionally, I have not kept the eye at the center of the operating field. It's a little peripheral, and this eye is also moving. But look at the brilliance of the red glow here. It is quite uniform, so there's no sweet spot. So that's what I meant when I said it produces a wide red glow. Irrespective of the movement of the surgeon's hands or the patient's head, the brilliance remains quite uniform. So it produces a wider and a more brilliant, and this is also important for me. I operate under very low magnification, so at a low mag, it has to give me proper resolution, and there's no compromise on depth, and you don't need to change the focus time and again to focus on the structure that is of interest to you. So let's look at a few case examples. Let's start with something that does not produce a red glow, a white hypermature cataract. And now in this, the moment I start giving the nick and start towards the periphery, I realize that it's about to run out. So I stop there because the cortex is protruding and is about to produce a radial tear. So I stop there, I push some viscoelastic, and I'm trying to retrieve it. Just then, it splits open and produces a half an Argentinian flag sign. I try to retrieve it, but that's too much of a pull. I leave it there. I give a nick, and while I'm trying to give a nick from the side port with the micro scissors, the other side also rips open, so I have a proper Argentinian flag sign now. But since the visibility is so good, I just create half of an opening to give me some access to the inside of the nucleus so that I have at least my working space down in there. The nucleus in these cases is usually soft. However, you need to have your precautions of not going to the area or close to the area which is weak, so you stay away from the zone which has been split open. So thankfully, we do have access to phaco machines also, which operate under extremely low fluidics. But one by one, the pieces have to be separated and have to be consumed, all the while keeping an eye on the posterior capsule. Since the red glow now has come back with the removal of a few pieces, you can see that the posterior capsule is intact and the split has not really gone on to involve the equator and the posterior capsule. A single piece IOL comes in because there is adequate capsular support and the haptics are placed thereby. And after we do that, since the capsular opening is too small, we can give a neck. Under cover of BSS, there's no reason to use viscoelastics in this. Then the capsular flap can be rotated on either side to produce a big enough capsular opening to hold the optic edge all around. However, the haptic also has got adequate support. So at the end of the day, the case looks good. The second case is an example where the red glow is marred to an extent because of the presence of zillions of asteroid bodies in the vitreous. The focus can go a little deep to focus on those asteroid bodies, which can show that the red glow is not very proper. Now, per se, this might not be a clinical menace, but it also is a situation wherein you might not get a 6.6 post-operatively. It might just stop at 6.12. So what I decide to do in such cases is, it's a toric IOL implant. So after implantation of the IOL, under cover of BSS, I go in with a capsulotomy needle from the side port, create a nick on the posterior capsule. Again, there's nothing that necessitates the use of viscoelastics in these cases. You can do all that under cover of BSS. So a proper PCCC is carved out of the posterior capsule, and once you have the doorway into the vitreous cavity, the vitrector cutter can go in and then start cutting the vitreous and removing the asteroid bodies in the process. Such people usually have very liquefied vitreous, so it's not very difficult. You can just stay right at the center and the cut rate remaining very high. And with the removal of the asteroid bodies, one can see that the dull kind of red glow comes back and regains its brilliance. That's where you know that the visual axis is largely clear and the red glow helps you achieve that. Next example is a deep socket wherein you would essentially have a strong flow of fluid, and the liquid film always occupies the surface of the globe, but with a good visibility. This is a hard cataract, although, but with a good visibility, and it's also helped by the fact that you use very minimal IOP so that there's not much of a fluid collection over the eye to disturb that view. So the IOP I'm using here is 20, and the visibility is proper for achieving the cracks. What also helps you in such hard cataracts is the moment the crack is complete, you can see clear daylight red glow coming in between, coming from the crevices that have been created by you, the cleavages that have been created by you. And after you have completed the chops, this is an unedited video. After you complete the chops one by one, the pies can be removed. Once you have completed the nucleus removal, I always implant my IOLs under BSS. There's where the IOP goes up, and now you can see the fluid film really connecting, but still within that collection of fluid, there's enough visibility for us to put down the red glow. This is the last of such of the series. This is actually a hypermature cataract, the lens-induced glaucoma, very shallow anterior chamber, and the subcapsular loose cortex, and the nucleus was very dense too. This was a one-eyed patient, interestingly. The other eye was a phakic, so I had to have my cautions, and the endothelial cell count also was not doing great. But still, now a change in the parameters. I trust the red glow of the equipment again to give me an idea as to where the chop is complete. The primary chop should ideally be complete before you go on to the secondary chopping of each of the heminuclei, because you have to ensure that the posterior plate is completely separated from one another before you start the emulsification process of the pies, thus separated. So once the chopping process is complete and the red glow helps you achieve that, then the pie emulsification process can start. The IOP remains at 20. I always have an eye on the CDE count since the endothelial cell count was low, as I said in the beginning. But the endothelial cell can be protected by a few injections of viscoelastic time and again, but with the help of the proper equipment. So that's what I do now. The CDE crosses 10 and I stop and I push in some viscoelastic before continuing, and then the other heminucleus can also be chopped and consumed in the same process as the previous. It is essential when we come out of the come out of the eye, when we go in after pushing in some amount of viscoelastic, it is important for us to keep the phaco in the aspiration mode for some time, because the visco itself, which is there inside the eye, can clog the needle. So we need to wait for some time, and then the rest can be taken out one by one. The CDE count is not great, but it is not bad either. I believe for such a hardness of cataract, if you are staying under 25, 26 of CDE at the end of the emulsification process of the nucleus, at least, you should think that you've done a reasonable job with that. So we finished off with thank you. Thank you so much for the attention, and thank you so much for the opportunity.
Thank you, Dr. Anurag. With this, we come to the end of our session, our instruction course. So for the audience, please do give your feedback on the AIS app. If you like this session, please do give your comments and help us in improving the course. Thank you. Over to you, KK sir. Your next thesis.